It was my pleasure last year to introduce Alan Weil, and I evidently did a really bad job. So I get to demonstrate how this works. I'm sorry, Alan. I'm sorry, it really works. So this time I'm going to bore you half to death because Alan has done so many things. Not really. Not that he hasn't done many things. I'm not going to bore you half to death. Alan, probably the newest claim to fame is he's the new editor-in-chief of Health Affairs, which I understand that everybody knows what that is, except me. So I'm going to have to figure out what Health Affairs is. He was the executive of the National Academy for State Health Policy, director of the Urban Institute assessing the new Federalism project, which is notable because this was the largest social policy research project that was privately funded. He, about 100 years ago, was the executive director of HICPUF and lived to tell the tale. There's some other refugees from that job in the audience, I noticed, so we'll have a reunion later. This one interested me. He was the Assistant General Counsel for the Massachusetts Department of Medical Security. So he's now going to be consulting to the NIH, who has now put all their germs in baggies, we understand. And so they need a little bit of work. He's been on the Institute of Medicine's board, numerous prestigious boards I'm not going to even try. And for fun, Alan hikes mountains and testifies before Congress. So he's got books, journal articles, he's an expert. Without further ado, please welcome Alan Weil. By the way, we will not only have the Denver Health Band tonight, but we will have more music tomorrow, so don't miss it. Thank you.
Thank you. Thank you, Sally. There are many advantages to being invited back year after year to the Colorado Symposium. I now am the proud owner of water bottles in every color of the rainbow: orange, yellow, clear, and this year green. I'm on my second backpack. My ping pong game gets better every year. And I've learned that if I make the mistake of tweeting that I'm hiking a mountain instead of listening to one of the speakers at this conference, at the reception that night, 25 people will come up and say, "How was your hike?" So I won't. This year I won't make that mistake, and the mistake will not be not climbing the mountain. It's, of course, great to see old colleagues, and it was actually only 20 years ago that the Department of Healthcare Policy and Financing was formed, and I had the honor of starting up that agency. It's great to be back in Colorado, but there is one big disadvantage to being invited back, and that is in January I got this nice note saying we're beginning to schedule the 2014 symposium. Would you be willing to come? And I said, of course, I'd be happy to do it. I always love being here. But in January, the theme of the conference has not been set. And so in April, I get this email, and it has the conference theme. And I realized that my job is to introduce the conference theme, but I agreed to do that introduction long before I had any idea what it was, and needless to say, I had absolutely no input into it. So here I am getting ready for this meeting, and I get the Colorado Health Symposium 2014, Health Transformed, the Power of Engagement. Now, I get health transformation, that kind of makes sense to me, but what is the power of engagement? Well, I open my trusty dusty Merriam-Webster dictionary. Actually, I Google dictionary and you get the Merriam-Webster dictionary. And I ask, what is engagement? This is not a term we use every day in healthcare. And this is what I found. It's an agreement to be married. I don't think that's what this conference is about. If it is, actually Sally, teed up the subject pretty well. But I didn't think that was why you wanted me here. And then I saw, well, it's a job or period of employment, especially as a performer. And that we clearly met with the Denver Health Band this morning. So now I'm beginning to get the feel of it. But then it gets worse. It's a hostile encounter between military forces. This is not the kind of health transformation I think we want, or it's an arrangement to meet or be present at a specified time and place, which certainly the symposium is, but is hardly a call to action. And finally, when you get to the very end of the list of the definitions of engagement, you get emotional involvement or commitment. And I think that's what the organizers had in mind. This is not about getting married or performing, although those are wonderful things, but this is really about engagement, meaning, involvement, and commitment. And so, with my job as the opening act, well, the second act, to focus on the substance of the conference theme, I thought, well, how could I introduce, for the few days you have ahead of you, the theme of health transformed, the power of engagement. And so I've come up with 5 engagements that I think will define the future of health, and I'm going to spend a few minutes on each of them to give you my perspective on what it means to have a symposium focused on the power of engagement. The first concept of engagement that comes to my mind is the theme of engaging the whole patient. If we are going to transform health, we need to engage the whole patient. Now, 20 years ago, if I'd come to what was then the Dorsey Hughes and talked about engaging the whole patient, people would have thought I was talking about doing yoga. It's funny how what goes around comes around. I think we do yoga now. But we didn't talk about the whole patient back in those days. 10 years ago, at this symposium, if we talked about the whole patient, we would have been just a few years after the Institute of Medicine's report Crossing the Quality Chasm, which included patient-centeredness as one of the 5 characteristics of quality. And we would have said engaging the whole patient, that's patient-centered care. And everyone gave a lot of lip service to patient-centered care, but it was, in my estimation, more talk than action. Now we've moved to the whole patient. The term we talk about now is population health, one of the 3 parts of the triple aim. If we are going to engage the patient, we engage the whole population and we improve population health. Now, when I think about engagement of the whole patient and why I put it first on my list, I'm thinking of 2 elements. One is the artificial distinctions that have grown up over our training and our financing between physical health, mental health, and oral health, and clearly the understanding today that when we look at a patient, we need to put those pieces together. And I think there's a lot of understanding about that importance. But it's also about understanding patients as a whole in their context, the world in which they live. And I'll just give you a very small example. My first daughter was born 5 weeks early. She spent a couple of weeks in the neonatal intensive care unit, and as new parents, we were all, freaked out about this, and it was very stressful. 3 years later, our third daughter was also early, and she spent 2 weeks in the NICU as well. But there was one really big difference for the second experience, which is we had a 3-year-old and a 1-year-old at home. And so our ability to be there for our baby in the hospital was completely different, even though from a medical perspective or just looking at it in general, you might have said, well, those were kind of the same situation. Francis Collins, who runs the National Institutes of Health, says that medicine will never be simple because people are complex, and certainly they are. He, I think, when he said that, or when I heard him say it, was referring primarily to genetic complexity in our genetic code. But as you all have heard and will be discussed more over the course of this meeting, we also know that your zip code matters maybe as much for life expectancy as your genetic code. And so if we're going to embrace the whole person, we need to not just embrace their biomedical or DNA complexity, but their social complexity. And that means bringing and thinking about the whole patient is thinking about them as a person with their own characteristics and their own experiences, and also where they live and how they live. So my first introduction to the theme of engagement is to say that the future of health is going to be defined by the healthcare system's ability to engage the whole patient. which leads me to the second form of engagement. I think the second form of engagement is our ability in the healthcare system to engage with social supports. Now, this again is an area that is getting more attention, primarily because of one very small but important provision in the Affordable Care Act, which is the penalties to hospitals for excessive rates of readmission for people after their discharge from the hospital. And it's created in every hospital in the country an understanding that when the person leaves their doors, what happens next might actually affect the hospital's bottom line, and it might affect them in a negative way if they're not attending to people's social needs. And suddenly, hospitals are investing in linkages and coming to understand the social supports that exist in their communities so that they can make sure that the person who's sent home gets the support they need so that they don't return unnecessarily to the hospital for something that could have been avoided through a simple visit to the home, a delivery of food, attention to someone's living circumstances. I serve on the board of the Consumer Health Foundation in Washington, D.C., and I was talking to one of my fellow board members who's in a hospital system in the D.C. area, and we were talking as a board about community health workers. And he was describing how the hospital was hiring a bunch of community health workers. And I said, gee, this kind of doesn't make sense to me. Doesn't the hospital hiring the community health workers sort of defeat the concept of a community health worker? After all, now they're an arm of the hospital instead of embedded in the community, which is where we thought they were supposed to be to promote population health and community health. And we had this really robust discussion. Now, my point in bringing up that example is to say that when we in the healthcare sector start talking about the need to incorporate social supports, we have this really bad habit. We go and hire them and buy them and think it's part of the healthcare system and deliver them and finance them the same way we do in healthcare. And the good news is we're a sixth of the economy, so we've got a lot of resources, and that gut reaction of, well, we'll just hire them and make them a part of us is sort of natural. It's built into the way we think about our healthcare system. But it can be really counterproductive. We have a lot of disadvantages in how we think about people and interact with people. We're very focused on individuals, not families or communities. I've had the pleasure of working with the Ascend program at the Aspen Institute that's taking on a two-generation approach to improving family well-being for vulnerable families. And as I've thought about what health contributes to that formula, we, again, bring all of these resources, but we treat everyone as an individual. And insurance is this annual contract, and we think primarily about illness and disease. And although there are plenty of elements of the social sector that are not as far ahead as we would like them to be, they tend to think long-term. They tend to think of families and communities. They tend to think of assets you can build upon as opposed to diseases that you can cure. And so as we engage the social support systems that are out there, which is something that we definitely need to do in healthcare, we need to bring the strengths of healthcare in that engagement, but we need to not overrun the strengths of the social support systems out there and lose the value that they bring, or else in the process of engaging with them, we will defeat and destroy the value that they create for promoting health in the broadest sense of the word. So the second engagement I wanted to bring to you is this engagement, this notion that the future of health is going to be defined by the healthcare system's ability to engage with social supports beyond our traditional walls of the medical system. The third engagement is the need to engage economics and anthropology. You know, economics focuses on the rational actor, the belief that everyone responds to financial incentives, and if you set the incentives correctly, you can create a path to the appropriate behavior that you want. And anthropology is rooted in ethnography. It talks about culture. It thinks about societies and communities and institutions in a much different way than economists do. And of course, as we know, both of these fields have a great deal to offer in thinking about the world, in understanding the world. In healthcare, the poster child for the power of economics is the implementation of DRGs. When we changed how we paid hospitals from per diems to a fixed amount based on the diagnosis, the change in behavior in hospitals was incredibly rapid. And hospital stays dropped. Concerns about bad outcomes actually really didn't materialize. We found that complex, sophisticated institutions could change their behavior very quickly when they were presented with a significant change in their financial incentives. So clearly we know that economic incentives make a big difference. But every time I read a case study of a successful institutional change, if you think about an organization that's doing what it's doing well, and then at the end of the paper, the author writes, here are the attributes that led to that interesting and successful transformation, the first item on every list is leadership. That there was a leader who took the organization, had a vision, defined a culture, and brought that institution into a new era. When you plan this conference, you don't just say, who's got the right financial incentives? Anyone who's facing those incentives could speak. You're looking for leaders, people who are going beyond the context in which they operate and taking the next step. So we know that anthropology and culture are critical to thinking about institutions. I had the good fortune in college to have as my undergraduate thesis advisor George Akerlof, one of the founders of behavioral economics. He went on to win the Nobel Prize, which it's kind of cool to have been his former student. I might also note his wife is the chair of the Federal Reserve, so no slouches in that family. But you know, so from the beginnings of my economics education, I was trained with people who thought about economics in the context of human behavior and didn't just think and assume that people were rational actors. And in that way of thinking, we understand that the force of economics and the force of culture are great, but they can also lead to unintended or undesirable consequences. I want to give the example in healthcare of where we are right now poised on increased use of quality metrics in thinking about how we hold our health system accountable. It's tremendous how much progress we've made in defining healthcare quality. But as we peg payment to quality metrics, we all have to acknowledge that the quality metrics that we have are not nearly finely enough grained to lead from a purely economic perspective institutions to true whole patient, patient-centered care. I mean, we've got 33 measures for accountable care organizations. People say you need to narrow the number down so organizations can focus on a few, but people are complex. And we are moving more to patient-measured outcomes and patient-reported outcomes, which is great, but even those are at this point still underdeveloped. If we think that financial incentives alone are going to move the healthcare system to high quality because we're going to pay for quality on 30 measures, we have a very poor understanding of quality and a very poor understanding of what motivates change. What we need to do is have the economic signals aligned with the cultural shift that we want. As we harness both economics and anthropology, we can have the healthcare system we want. So the third engagement that I think will define the future of health is our ability to engage both economics and anthropology in our thinking about what outcomes we want and how to affect change, and not to rely solely on one of them. The fourth engagement, I couldn't help myself. I've been a student of federalism and practicing in state government all my career. So to me, the fourth critical engagement for health is engaging federal, state, and I add local, although I don't fancy myself an expert. I give a lot of guest lectures to students about federalism. And I always begin my lectures with asking the students to explain in the abstract, why might you want the federal government to do something? Why might you want the state to do something? And they always come up with really good lists. You know, the federal government's very good when you're trying to redistribute resources. It's very good when you have boundary problems, because the example often used is pollution. If pollution flows across state lines, down the river, or through the air, you need a federal structure to prevent one state from adopting very loose standards and exporting their problems elsewhere. If we're concerned about equity, then we tend to take national approaches. But of course, states are closer to the people, they're more nimble. In our federalist system, they run a lot of programs. We are at the point, somewhat by accident, but not entirely, where public funding is now half of healthcare. Whether we're talking about federally run programs like VA, or federally financed programs like Medicare, or jointly financed programs like Medicaid, if we don't harness the power of the public sector in the transformation that we want, we will never get where we need to go. And of course, the public programs tend to disproportionately serve the most disadvantaged, and that makes the harnessing of these different levels of government more important than ever. But we tend to fight across these boundary lines. Most Americans don't have a fine distinction of what's federal, what's state, what's local. They just think it's government, and if we don't get our act together, we are not serving them well. Going back to my prior topic, you know, loosely I would say the federal government is better at economics and states and localities are better at anthropology. That is, the feds are good at moving money around and setting broad structures and frameworks. States and localities are better with actually working with institutions and figuring out how to make things work. So you want to do pay for performance and you set a big national structure, but you want to figure out what the metrics are going to be and how the dollars are going to flow and who's going to get the payment. And that's got to be based on trust and communication, and those kinds of things happen more effectively at the state and local level. So these big ambitions that we have for transforming health, the healthcare system require alignment. And then similarly, when you think about public health and population health or promoting health, we can have federal, national initiatives to promote activity and reduce obesity, but at the end of the day, it's people interacting locally in their communities and interacting at their schools and their communities that will determine their behavior. So my fourth engagement that I posit to you is that the future of health is going to be defined by our ability to engage effectively across federal, state, and local governments in the system transformation that we need. Which leads me to the final engagement that I want to spend a moment on as we start off this symposium. We often hear about the doctor-patient relationship, the sanctity of the doctor-patient relationship, the importance and the need to honor that relationship. And I accept and agree with that formulation. And yet, as we think about the redefinition of health and the redefinition of the resources we need to achieve positive health outcomes, we know we're going to have to engage a broader workforce. It's not about just the doctor. It's even not just about the nurse. It's about, as I mentioned, the community health worker. It's about the dietitian. It's about all sorts of professionals, people with a wide variety of training that are going to contribute to high quality outcomes and good health outcomes for the population. But let's not kid ourselves. We can talk all we want about the importance of engaging a broader workforce. The fact is the doctors hold the keys to the kingdom. They control most of the institutions that need to change in order to achieve a more holistic approach to meeting the needs of patients. When I go out and visit institutions that claim to have, and by the evidence, have gone beyond traditional focus on clinical medicine and are trying to work more broadly with patients as a whole person in the community, the leadership for that does come from the physician leadership of the organization. And I sort of thought, why does this have to be? And the answer is, if the doctors don't want to make the change isn't going to happen. And it brings me back to that defining feature of engagement, which is this notion of commitment. About 15 years ago, I fractured my patella, my kneecap, not a fun injury. It's not been bad, but about a year ago, I started having a significant amount of pain again, and I went back to the orthopedist who I had gone to initially when this happened, and he took an x-ray and he looked at me and he said, "You don't want me to cut open your knee. What you need to do, the reason you're feeling this pain is you've got some misalignment. You need to go to the physical therapist." Now, you know, like every good American, I'd rather go under the knife for an hour than have to go to a physical therapist 3 times a week for 3 months. But I did it, and it fixed my problem. But what struck me is that the doctor said to me, "There's someone else who can give you what I can't give you. They have the training, they have the time that they'll spend with you, they will align and adjust you, they won't see you on a 10-minute increment. I bless them as the person who can take care of you." So it was the physician leadership that enabled me to feel comfortable. I wasn't getting second best. It wasn't, oh, I want to see the doctor, but I'm being sloughed off to the PT. It was that the doctor in relationship, no, I would say the doctor engaging with me was sending me to a place that was better for me to get my care. And that's a very different way of thinking about the doctor-patient relationship, because that engagement enables a change in how we receive our care. So the final form of engagement that I present to you for consideration is that the future of health will be defined by our ability to transform the doctor-patient relationship into a doctor-patient engagement, which is a more dynamic and more of a commitment than just the term relationship. So let me close, as I put these 5 up on the screen for you, let me close with 2 final thoughts about engagement as we enter into the rest of the symposium. The first is, you may not have noticed, I would forgive you if you didn't, but in each of the 5 areas of engagement I just presented to you, I told you a story about me. And I want to, as we kick off these few days, to remind you that the concepts of engagement and commitment are personal. And if all I do is put up slides and talk about payment reform and papers that we publish in Health Affairs, you may feel educated, but I doubt you'll feel engaged. And so I would encourage us, as we do our work, to incorporate not just someone else's stories, but our own stories in our communication about healthcare and health, so that we give meaning to engagement as an act that requires giving of oneself, not just presenting what we know in our heads. And the final thought is to say what I know you all know, and I feel every year when I come here and to the many other conferences I go to. But I think, again, given the theme for this year, it's worth reminding ourselves. Everyone in this room and everyone we work with is ultimately affected by health policy, health care, the healthcare system. But the most significant effects of the decisions we make are felt by people who never attend this or any other health policy conference. The greatest burdens of illness are carried by people who never attend this or any other health policy conference. On average, and I understand this is an average, but on average, Americans are poorer, they're less likely to be white, they're less likely to hold a graduate degree and certainly a bachelor's degree, and they're on average sicker than the people in this room. They have fewer assets. They have fewer monetary assets, and many of them have fewer social assets to turn to when they're in need. Unlike most of us in this room, when they or a family member are sick, they can't just pick up the phone or send an email to the head of a hospital or the head of a medical specialty society and say, someone in my family has X. Who's the best person in the country? I'm going to get them there. That is not the typical American's experience with the healthcare system. So if we are going to engage with them, and that is our theme, and by engage, that means to make an emotional commitment to them, I suggest we start by listening to them more. As Sally said, listening is really important. Listening to them more, judging them and the choices they've made a little bit less, and work to build a healthcare system that meets their needs and their values, not just one that reflects our own. To me, that is the power of engagement. Thank you. And now I get to